I'd like to welcome everybody to today's webinar, Hospital 2018 Reporting Requirements, Stage 3, and the Finalized IPPS Rule. My name is Scott Mash, and as always, I'm joined by my partner in crime, Miss Cathy Costello. Now, CMS has been busy. There are one final rule and 3 proposed rules. Today, again, we're going to focus on the Hospital IPPS Rule. That was released. The final rule was released back on October 2nd, but
August 2nd.
I'm sorry, August 2nd, but becomes effective on October 1st of 2017. The rules that are out there right now in proposed form are the 2018 Hospital Outpatient Proposed Rule, the Physician Fee Schedule Rule, and then the modification to macro MIPS and APMs. We are collecting comments on those rules. Actually, we've already submitted our comments on
for MIPS.
For the MIPS rule.
Done it. The Hospital Outpatient Rule and the Physician Fee Schedule Rule are still accepting comments.
So with that, I'm going to turn it over to Miss Cathy Costello, who's going to take you through most of the today's presentation.
Hi everyone, thanks for joining us. What we've tried to do this time, as you all know, you've suffered through this as we have for close to a decade now, is that CMS has split out information amongst many rules. But when it comes to working with hospitals, especially hospital systems and physicians, it may be that you need pieces of information from every rule. So we've tried to draw things together. We primarily have focused on what is final in the hospital inpatient rule, but in other places where we felt you needed the information, we have included information from the proposed rule, and I'll identify as we go along what is proposed and what is final. So let's start with the technical questions. For those of you who are on the technology side, you know 2018 is going to be an enormously busy year. And we're going to look at the timeline in just a minute. But the important thing is you have to recognize the scope of what you're having to address over the next year. Despite all the changes in reporting periods, the reality is you still have to develop a timeline that addresses all the various goals that CMS has for you over the next 2 years. So the first thing, and probably the most major for everyone on the call, is when is your organization planning to do the Stage 3 upgrade? And we're going to talk about the possibilities of taking it early or late and what that's going to mean. The second and related question is, whatever you do with the hospital, what is being done on the physician side or the practice side to take those Stage 3 upgrades and to do the change in workflow? What are the advantages and disadvantages to staying with Stage 2 versus going with Stage 3 earlier in 2018? And the question that's really going to drive a lot of your answers is, how ready is your vendor? And the vendors, the 3 biggest new areas that your vendor has to let you know how they're planning to address is the API functionality that goes to the patient portal. It's the option that allows for the portal information to push through to an iPhone or something similar and combine information from more than one portal. The second one is, how is your vendor planning on capturing what is called euphemistically in the rules patient-generated data, which is really data from anyone other than a hospital or a physician office. And then the third area is, are you fully integrated for query and retrieve through, this is usually done through HIE functionality, whether it's CliniSync or some other HIE. I know there are many different strategies going on there, but that is something that you will have to look at and map into your timeline. Another question that comes up, although it is not required, most organizations we have talked to in Ohio are spending a lot of time on the question of, are you planning to do e-prescribing of controlled substances? And this is one of those areas that, although CMS walked right up to the edge on this and then backed off, they are not requiring, but let's just say it's highly recommended that you get the EPCS system as part of your e-prescribing. And this is something that hospitals, because you are moving this year and next year into ERX at a much higher rate than the physician practices that were doing this way back 5, 6, 7 years ago. It's something that you want to take into account on your technical timeline. And then the very last thing is, what about the appropriate use criteria for imaging? This is an area, this is really has to do, and Scott's going to talk in more depth about this shortly, has to do more with how you order your imaging studies and what the documentation is and whether it's a best practice. And CMS keeps pushing the timeline back, but this is something that absolutely needs to be built into your 2018 timeline, because I think CMS has now gotten to the point where they're setting final deadlines on that. So something many of you have seen numerous times over this year and last, but this is the technology reporting for Medicare physician or provider groups, Medicaid, and then the Medicare hospitals. And although every time we've used this, it's been for 2017 reporting, the reason we put this up again is just to reflect in your mind, with something that you're used to looking at, that 2018 is going to look just like 2017 in a lot of ways. It's not how you implement it, but what are the basic requirements. And you will continue to have the 3 buckets that you'll have to think in terms of what are your physician and ambulatory providers who are participating in MIPS, whether they're part of an alternative payment model or not. Virtually all of them are covered by MIPS. What's the reporting required there? What's the technology? Then if you are still drawing down Medicaid incentives, what do you need to do for that? Because those are 2 totally separate programs now under the regulations. And then the third thing is, as a hospital and as supporting the hospital's reporting, whether it's through value-based purchasing or some of the other hospital IQR reporting programs, what exactly needs to be done and what's the timeline? This is a final timeline for the hospital. Okay, right now, 2017 and, as I mentioned, 2018 are looking exactly the same. And when I say exactly the same, that means that you can either attest to stage 2, modified stage 2, or to stage 3 in 2018, the same decision that you made this year. You will have that pared back set of metrics where you're not having to report CPOE, clinical decision support. And please note, as a hospital technical person, that you are only having to report 3 public health reporting measures. And we are planning on having the Ohio Department of Health in September to talk about public health reporting and any upgrades they have or anything like that. So watch for that in your list of upcoming webinars. The thing to keep in mind in 2018 is what had been proposed before this reg became final. What we saw last year is that everyone thought they were going to have their stage 3 functionality in place through their technology, and they needed to have the 2015 edition cert in-house. And as you know, in the proposed regs for the hospitals earlier this year, CMS was toying with that idea of going back to what we called a look back or a flex period, where if you were not able to do stage 3, they were going to allow you basically to give a narrative about what was wrong with your vendor or what problems you're having with internal workflow, and then you could use stage 2. Well, they took a fair amount of heat on that in the regs, and basically people are like, really? Why are you doing this? And I think the reality is that is very labor intensive, both for CMS to do a look back that requires basically them to affirm every single hospital that's not able to do stage 3. And it really went across the, away from the concept of trying to simplify reporting and to recognize what the hospitals were having to face as they moved into stage 3 with all these other additional requirements floating around on quality reporting. So in the final reg, CMS discarded the idea of doing a flex period or a look back, and instead just said, okay, all right, we're just going to push off until 2019 the requirement for a hospital to do stage 3 reporting. And this fell in line with what they were talking about for the physicians, which we will look at in 1 second. But the reality is they not only did they say, we're going to allow you to keep your stage 2 certified system or to use a combination of stage 2 and stage 3, so 2014 edition or 2015 edition or a combination, and which really puts it back on you all and gives you so much more breathing room about when to take upgrades and whether or not all your modules are working, whether or not you have all your workflow in place. So really, I think Scott and I both feel this was the best possible thing that CMS could have done. We were hoping that they were going to push off the stage 3 until 2019, but you just don't know. But it is final now, and this is final, that you will have stage 3 reporting, or I'm sorry, stage 2 or stage 3 reporting in 2018 for the hospitals for 90 days. Any 90 days of your choosing. And we'll talk about how this also feeds in with your IQR reporting in a minute. The one thing that was not addressed in the rule, and I have to bring this up only because when you're plotting out your timeline, you do have to take this into account. And that is unlike on the physician side where there was a discussion and some resolution about what CMS was planning on doing in 2019 for the hospitals. There was no discussion about 2019. So at this point, I would say your game plan is to develop your strategy around 2018. Either do stage 2 early and then do your stage 3 upgrades and workflow, or hold off until the last quarter of 2018 and do it all as stage 3 with only a look back to stage 2. I shouldn't say look back, I don't want to confuse you. With the possibility of reporting stage 2 if for some reason you should have problems. But the reality is you have to have that stage 3 functionality up and going prior to January 1st of 2019 under this rule, because it is absolutely silent to any rollback of 2019. So your planning period is all 2018, your implementation is 2018, and then plan on hitting the ground running January 1st of 2019. How does this fit with the physician timeline? Same scenario for 2018 in the sense that your physician practices can either report under stage 2 or stage 3 or a combination, and I believe this also covers all your alternative payment models because those are linked back into the MIPS Quality Payment Program, QPP. And so any changes that are made to that will also be reflected in your alternative payment model ACI reporting. The difference here is that CMS has taken it one step further on the physician side, and at least for Medicare reporting, so under the QPP program, it is both proposing and had finalized, I believe, last year, that the 2019 reporting under QPP for ACI, so basically your meaningful use technology reporting, is 90 days, which is nice because then you know you have a little more wiggle room in 2019 to work a little bit more with your physicians and your practices if you have issues related to the payment program and getting into stage 3. What this is not, again, I have to point out that because the Medicaid program is separate from the Medicare, we do not know yet whether Medicaid would also be rolled back to a 90-day reporting period or not. So I think your strategy is on both the hospital and physician side to try to get as much work done in 2018 to prepare for 2019. Should you have to start the practices on January 1st the same way we think you will have to do for the hospitals. Okay, and this just says in words what we just talked about, and that is that you have this option in 2018 as to how you're going to report. Okay, the one thing I would say is that if you're part of an organization that is responsible for ambulatory surgery centers, ASCs, they managed to very neatly slide into the CURES legislation, which was passed at the end of last year, an exception for 2017 and 2018 reporting, and you will not have to report for them at all, and they will not receive a penalty. Their definition of an ASC provider is one that bills at least 75% of their Medicare Part B at POS 24, place of service 24. This is regardless of whether the ASC is owned by a hospital or whether it's independent. Okay, just a reminder for the hospitals, when we talk about moving to stage 3, this is what you will be looking at as far as your measures. As I said, CPOE and CDS are totally out. Your public health reporting is pared back from what was originally proposed, or not proposed, but finalized under stage 3, was that you would have to do 4, but rather it's CMS has now stayed with 3, which would be your immunization, your syndromic, and your electronic lab reporting, assuming you can do all 3 of those. You will have e-prescribing move up to 25% from the 10% that you have been working with right now as you move into stage 3. This may or may not be an issue depending on your strategy for getting your hospital onto e-prescribing. We've seen a few hospitals that had done their strategy based upon starting with inpatient and then moving to ED or vice versa. And so you do want to look at your numbers at stage 2 and see whether or not you're getting up close to 25%, so you know how ready you are in making that decision about when to do stage 3. The patient electronic access measures are the same, except you are required to have that API reporting.
Yeah, and you also see that they now include the patient education portion or measure under the patient electronic access, because the intent is that that education not only be provided in print to the patients, but also be available through your patient portal as well.
For
the coordination of care measure, this is one of the measures where CMS would like you have to meet 2 of the objectives within the measure, but you will be reporting on all 3.
Right. And the view, download, and transmit stays at the 1 patient for the hospitals. So you're basically looking at those 2 new elements, secure messaging and your health data incorporated, which is the patient-generated data. We're going to look at that in a minute. Let me just say the secure messaging for the hospitals is a bit of a challenge because hospitals have never had to do it, but you should be aware that under the FAQs for CMS, the concept of secure messaging, they're finally catching up to the change in workflow that we've seen with organizations, and that is that secure messaging can be done as part of a chronic care management program, and if the hospital is administering that within their system, that could be used as part of your tracking for secure messaging.
And that's in addition to what you would maybe do around discharge planning as well.
Correct, correct, exactly. So if you have hospital staff who's supporting your transitional care management and then doing a handoff to the primary care practice at the time and once the scheduling is done, this is something that you want to be looking at and developing how you're going to make sure that that gets captured within your hospital system to report on for secure messaging. Now, under the Health Information Exchange, the first one, summary of care sent electronically, you've all been doing for a number of years. Request accept patient record is the query and retrieve. And then the clinical information reconciliation is the expanded, what used to be just MedRec.
Yeah.
Okay, and what I want to spend just a minute on the patient-generated data, because this is a new area and the CMS information is very, very broad on this. So this is straight out of CMS. I just want to make sure that you are aware of what they are saying.
Yeah, and if you read through the rule, many times CMS refers to this as non-clinical data, though
we all know it is.
So.
But if you look at this, what this basically is all the information that goes into putting together a patient's complete data information regardless of site. So if you have a chronic care management program and you're working with, social service agencies to provide care, this is one place where this can be part of your, quote, patient-generated data. You can, as a hospital, I know a lot of you had done some planning around advanced directives. This obviously is a big area that can be incorporated into this. Certain monitoring data, whether it's from a health monitoring like a cardiac system or whether it's a patient-generated, these are all areas that CMS will allow you to capture in this. But your issue really is, what the heck is your vendor doing about it?
Right. And also, when we say this is patient-generated data or patient-provided data, it's important to note that this data, if it comes from the patient, it has to be outside of the encounter or stay. So this would be before or after they spend time in the inpatient setting or outside of the time they're in the ED or whatever. So.
Right. And these are a list of the things that CMS lists as things that could be patient-generated data. But it by no means is complete. Here are the list of providers that CMS is saying you can include information from them in this category. Again, it's not complete, it's examples, but look how broad that is. It's basically your behavioral health providers, your PT, OT.
Yeah, your hospital outpatient services.
Yeah, there's all kinds of stuff here. And so what we're telling people is this is a measure that is not going to be difficult to track, but is absolutely critical that you understand how your vendor is planning on capturing it so you in turn can prepare your staff on what the workflow is. And the other important part of this, and again, this is straight out of CMS's guidance, is that it does not have to be discrete data. It can be either discrete or it can be done as an attachment, especially if you are unclear as to the value of the data. I mean, that's not the only reason why you might put it in as an attachment, but let's recognize that something that comes off of say a cardiac monitor may be a whole lot more precise than something that comes off of a Fitbit or a phone app or something like that.
Yeah, and this data doesn't have to be stored as part of the primary record. If your EHR has the ability to create a secondary record or just use a link to another document, then that is allowed. But again, it all goes back to how is your EHR vendor going to implement this functionality? What is the workflow that they're developing to make sure that you get credit for this medicine.
Yeah, we're guessing that most vendors are going to give you credit for any attachment that's done to the patient's record, but you want to clarify that with them so you understand how it's captured. 5% is going to be nothing for a hospital to capture, depending on how their vendor allows it to be calculated in their numerator. But the important thing is just to map that into your preparation for your workflow education. Okay, now I'm going to turn it over to Scott to talk about appropriate use criteria. This kind of feels like an old shoe that's been dragging around for years, because CMS has been talking about this for 3 or 4 or 5 years in the planning stage, and we're just getting to the point where this is something that you really have to get done within the next year. So with that, Scott, I turn it over to you.
First, I want to start by saying that we're not going to go very, very deep into the appropriate use criteria requirements right now. When CMS finalizes the physician PPS
fee schedule
schedule rule, we are going to do a deep dive into appropriate use criteria, because that's where the last piece of the puzzle is going to be finalized. But at any rate, if you're not familiar with the appropriate use criteria, this is what a CMS has developed with the intent of this functionality, assisting clinicians in selecting an imaging study that's most likely to improve the health outcomes for patients based on the underlying rules and clinical information. That's the CMS definition. Really what this is this is going to be functionality that an ordering provider is going to have to use to see that the study that they're ordering for that patient meets the requirements based off the clinical information that is available for that patient and the intent of that of the ordered study. Now CMS has been working on the guidelines, requirements for this since we first saw it in the 2016 proposed rules and final rules. The definition of the clinical decision support mechanism came up in last year's proposed rules, and now the final information for the inclusion on claims form by the furnishing professionals, some exceptions, and a couple other tidbits of information we're seeing in the proposed and final rules for this year. The biggest thing that we need to note is that in previous years they said, hey, 2018 is the year, you got to have everything ready. Now, thankfully, with everything else going on, CMS now has said that you got to be ready by 2019. Now you can use it in 2018 and you get extra credit. This is it's actually
for the physician.
Right, on the physician side, if you're using AUC, the appropriate use criteria, when ordering a study, you do get credit under MIPS for CPIA, so that's something to consider. Now,
yeah, but basically what you're looking at here, as you pull it all apart, CMS spent like 2 years plus setting up what are best practices, and then last year they moved into what's the technology that's going to be built and how is it going to be implemented. And now we're into let's get the physicians and ordering providers who order it to make sure that they're looking at the best practices in AUC that's now been built into your hospital or physician system. And the very last piece is, are you coding for that under the claims? Is the radiologist who's doing it making sure that that information with the AUC is also on the claims coding side?
Yeah, so there's some G codes and whatnot that are being proposed that have to drop to the claim form. Also this year we saw the inclusion of exceptions. So if it's, if you got a patient that's coming through the ER or in the inpatient setting, they are exempt from the appropriate use criteria. And there is a hardship on the physician side or provider side. There's going to be a hardship that you're kind of coupling with the EHR program that's going to be available for only 2019. There's not going to be a long-term exclusion for this program because of the dollars attached to it, quite honestly. So let's talk again from a very high level. What are the requirements of the AUC CDS, or the appropriate use criteria clinical decision support rules? The goal is for the CDS, or the CDS-M as it's also referred to be built into the ordering workflow. ideally to be part of the EHR because the CDS is driven in part by the clinical information for the patient for which the study is being ordered. So it's going to look at the problem list, it's going to look at procedures, it's going to look at kind of a few little tidbits of information, run it through the CDS rule, and then we'll present to the provider whether or not that ordered study meets the CDS requirements. If it does meet the requirements, there will be some supplemental information for the provider that will be available if they want to read that information or provide a little bit of more information to the patient. If that study does, or that ordered procedure does not meet the requirements, the provider can still override it. They'll have to provide some information why they're overriding it. Odds are it's still going to be paid as long as the supporting information meets all the requirements, but it will also point out to the provider why did it fail the rule, why is it not being approved, as we'll say. But it does provide immediate access to all the supporting documentation. Now, while the CDS sitting in part within the EHR is the ideal situation for both workflows, efficiency, and also access to information, the CDS can be a standalone product. It can be, a local application or something in the cloud. Though, if that's the case and there's no integration between your EHR and the CDS or appropriate use criteria CDS tool, it may require that some additional information be provided, like the problem and just some information about the patient.
But again, something that your vendor, your EHR vendor, knows well that this is on the timeline and should be able to talk to you about how it's being fulfilled and whether it's a separate module or exactly how closely integrated it is within your system.
Yeah, and there will be a list of qualified, recognized vendors that CMS is going to include in the Physician Fee Schedule 2018 final rule, but they do have a small list of approved vendors now because many of the vendors have been out there and working on this functionality. Now, the actual underlying rules for the CDS have been developed by CMS established provider-led entities, or PLEs, a group of physicians that work together to develop the underlying rules for the CDS to say, here is where this study would be appropriate for these given conditions. So CMS felt it was important that if they were going to hold physicians' feet to the fire, that a physician group develop the underlying rules. So the areas of priority for 2019, when this becomes a final rule, or when it becomes required, and also this will be for 2018 where it's optional, but the priority areas are going to be chest pain, abdominal pain. You can see the list here, but this is really the high dollar studies or other areas of focus that we see for CMS, like that low back pain. We've got quite a few, there's a heavy focus on that for CMS just because of the dollars attached. But for these conditions, the appropriate use criteria will run for the study that's ordered. And again, these are mostly your high dollar, your MRIs, your CTs, though there are some standard film orders that will be included in this as well. And as we progress past, into and past 2019, this list is going to be expanded over time. So I'm going to turn it back over to Miss Cathy to talk about IQR reporting.
Okay, it's kind of interesting to watch what's going on with the quality reporting, especially in the hospital space, because basically what you see is CMS, now that they put into place all the pieces of the puzzle, sophisticated EHR systems, ICD-10 as far as claims reporting, and the quality metric reporting, they're bringing it all back together now and using it to promote certain of their specific high priority items that they have as an organization. And they basically, what you'll see is the changes in IQR go to some of the highest risk patients and highest risk areas where they're trying to bend the curve, shall we say, as to how the patient care is provided. The first thing you need to know, very important, those of you who work in the technology area will probably breathe a sigh of relief, but CMS, again, after a lot of back and forth in the proposed regs, has decided once again to push back the IQR reporting requirements for eCQMs, so for the electronic transmission of CQMs for the hospital. For 2017, you are now rolled back to 4 eCQMs, same as you had in 2016, and the requirement will be for only 1/4 reporting. And it is up to your hospital organization to make that decision as to which quarter you are reporting. This is a change from what had been proposed in the IPPS rule released earlier this year. So please make sure that your report writers and your people who work on the eCQM side are aware of this. The equally important part of this message, and when you think about everything else you've got on your plate for 2018, you can understand why, is that 2018 will look exactly like 2017 as far as eCQM reporting. You will have to report 4 eCQMs for 1/4 of your choosing. And this is final. This was language that was final in the IPPS rule. And the significance of it is it should give you a lot more flexibility on this question about whether you're going to do stage 2 or stage 3 in 2018 and what your timing is going to be. So we've had a lot of people, besides hearing an enormous sigh of relief from many sites, it gives you more of a strategy around how you're going to do your reporting next year, because it could be that you're going to run your IQR at the end of this year and then just run the first quarter of 2018 for your IQR and then just move ahead with all your stage 3 changes after that. But please recognize this is final. It is a rollback from the proposed regs. Let's talk about some of the specific changes to quality metrics. And the HCAHPS survey, I found one of the most interesting. This, as a quality metric, CMS spent over 60 pages in talking about this in the final hospital rule. The normal proposal for putting out quality metrics for the hospital is supposed to go to NQF, National Quality Forum, for vetting and approval of hospital metrics before it is adopted by CMS as a requirement for the hospitals. This rule was an exception to that process. And what CMS says, and you'll see this in all their regs this year, there is really a lot of concern about opioid use and tracking it within the hospital, especially the ED, and then the ability to use this information to help target what the preventive programs are going to look like and to get into actually making it useful information for the community. So the HCAHPS is the first part of this. We'll look at another metric that's affected by this, but the HCAHPS, they were so concerned about that CMS bypassed sending it to NQF before it was put in as a final reg. And this is final. This is a final change. And instead they adopted it themselves and said that they have sent it to NQF for their review for next year, but this is exactly what the process is going to look like in 2018. So the current pain management, this is, as you know, HCAHPS, it is the patient satisfaction surveys, and the current pain management measure for the inpatient setting is, did the patient need the patient, did you need medicine for pain? Was your pain well controlled? And how often did the staff do everything they could to help you with your pain? Well, CMS was so concerned that this particular metric was driving the overutilization of opioids in the hospital setting that they have now changed this. And this is what the new measure looks like. Instead of saying instead of being an outcome measure, you patient, you feel that your pain was well addressed, it becomes a process measure. So have you, staff at the hospital, communicated well the need for information about pain, and not whether the more subjective measure as to whether or not the patient felt the pain was actually controlled. So now the communication about pain measure is, did you have pain? How often did the hospital staff talk to you about this? And how often did the hospital staff talk to you about how to treat your pain? And so this is the process. The difference here is that CMS is not going to report this result on these HCAHPS surveys until 2020, based on 2019. This is to allow hospitals to really get in and work with patients, understand how they're going to work with communication of pain and how it's to be captured. But it will not be reported as a public data until 2020. Okay, what I call the companion piece on opioid use in the hospital is a proposed change to the ED throughput measure for the outpatient that shows up in the OPPS, or the Hospital Outpatient Rule. This is not final. It will be final in October, but it's not a difference in the capture of the metric, but in how it's reported. So as you know, the ED throughput, the publicly reported part of the measure, goes to generally, what's the time that it takes patients to get through the ED, and just gives you the median time for that. What CMS is now proposing to do is to also release the information about the Part C, OP18C, which is the median time from arrival to departure for discharged psychiatric and mental health patients. But what the underlying discussion is really about use of the information coming out of the ED to track through use of ICD-10 the actual situation of diagnosis and whether this is an opioid. The patient has been sent there because they have had an overdose, or what it is. But you kind of get it captured. Both the what you call the psychiatric cases are also captured in this clearly, as well as overdose information. But that is what CMS appears to be going in wanting to publicly report this, is to make this information available at a deeper level as to what is bringing these psychiatric cases into the ED, so it's better understood how they can be treated. And this particular reporting is going to be made public as early as 2018, and it's going to be based upon data gathered right now, what's going on in third quarter of 2017 on. And they are going to be looking at the ICD-10 codes for substance abuse as part of this. Second change on the IQR reporting will be they are including the NIH Stroke Scale for hospitals' 30-day mortality reporting. And this, again, is driven by two factors, one being the broader adoption of the NIH Stroke Scale by most hospitals, and the second one being that due to ICD-10 coding, there is so much more information available about these patients, in this case, the stroke patients who become more part of the mortality statistics and trying to understand, is that preventable or not? And so that is why they are going to be looking at including information from the NIH Stroke Scale as part of that reporting. And they hope to use that to give greater predictive value as to what is causing patients with ischemic strokes to basically not be able to be assisted, and if they end up as mortalities for the hospital. And they are reducing the number of risk factors to 20 from 42. And this would begin based upon data collected starting in mid-2018 and will be publicly reported in 2022. The third new measure is the hybrid hospital-wide readmission measure, and this is, again, final as part of the inpatient rule. This is voluntary reporting in 2018. CMS is planning to make this a requirement, but they did back off setting a date for that until they see how this works. This is the first time that you see CMS gathering together in one place as part of quality metrics the ECQM information from the clinical side with the claims data on the claims side. And what they're trying to get at here is to get a better idea of what is creating the highest risk for readmission. And it's like the golden apple that they're constantly trying to go after to figure out the best possible care. And in this case, what can be done to prevent readmission? And they figure if they can figure out what's causing the readmission and what the underlying data shows, as I said, they're getting so much data now, it's how best to use it, that they will understand better how to predict which patients need that more intensive hands-on care or maybe a longer hospital stay or whatever. So they're going to be looking at this for at least 50% of the measures. As I said, this is voluntary for hospitals for next year, but just be aware it's coming down the pike. And what they're going to be looking at on the clinical side is this list of clinical information, and they're going to marry it with this information from your ADT feed, admission discharge, sex, date of birth, your Medicare ID number, and your CCN for the hospital. And that will be applied for any unplanned readmissions. Okay, the last big area I want to mention to you before we get into filing for exceptions is the facility-based quality scoring. This is proposed. Right now it is proposed voluntary, and it shows up in the hospital, or I'm sorry, in the physician MIPS proposed rule. And just so you people who deal with hospital quality understand it, because you may get questions about it, is this would apply for providers who work in the inpatient or the ED setting. At least 75% of their billing comes from that area. Providers would need to affirmatively elect to participate in this, and what this does is replaces the requirement to be involved in the MIPS reporting with allowing that provider to be covered by the hospital's IQR reporting for their value-based purchasing. So if the provider elects to participate under the facility-based, then you need to do nothing else, or they need to do nothing else either, but you need to be aware of who is covered by that. And that would be in the final rule coming out in October. Here are the measures, as you all know, that are included in the value-based purchasing. The IQR measures, they're all the ones you're familiar with, go on to safety domain, and then the cost of care. And whatever, at least as it's been proposed, whatever the hospital would receive as a plus or minus based upon their value-based purchasing score would also be attributed to any of the ambulatory hospital-based physicians or other providers who practice at their facility and have elected to participate. The very last thing before we let you go is I just want to point out a change in process, and that is the extraordinary circumstances exception, which I think many of you have had to deal with these over the past 7 or 8 years. If there's something that prevents you from, or your providers from attesting, and you have to file for it, in the proposed hospital outpatient rule, CMS says it's trying to standardize the whole extraordinary circumstances exception across all quality reporting programs. And so basically what it's saying is if you feel that you've had an extraordinary circumstance that's going to affect your hospital's ability to report quality, then you want to go in within 90 days and file with CMS with your narrative to explain why you think that it can't meet the IQR requirements for that year. And the CMS says it's going to make every attempt to let you know how you do within 90 days. The difference here is you're not doing an after the fact filing. You are filing in the current reporting year. So keep this in mind, that this is going to finalize your filing by December 31st of that year. So keep an eye on the situation. If you feel that your organization is not, and say you're doing a major upgrade and you just can't move between the systems well enough to get that second report available, you don't have the correct upgrade that is necessary on the old system to report your quality metrics, whatever it is, look at doing that filing sooner rather than later, rather than waiting until the end of the year and figuring out what you're doing about all your filing. So those are the biggest areas that we have for you hospitals, and as I said, we are going to be looking at having that ODH webinar. I don't know if we have a final date for that, but it's going to be mid to late September to talk about all the public health reporting, and then we are going to be doing final on the physician and the hospital outpatient when those become final in October.
Okay, we are now going to go to our questions that have been submitted. Now, again, if you do have a question, find the questions feature, go to webinar, type your question in. If you can't find that, find the chat box, and we'll go there as well. First question, the hospital portion of the rule clearly defines the CERT version for 2018 and also for MU objectives for EPs. However, it lacks the same granular detail in relation to CQM reporting with regards to the CERT version for 2018 reporting. While it is implied that 14, 15, or a combo can be used, it's not clearly stated, and CMS refers us back to state levels. What is clinicians' interpretation? It looks like they're talking about which CQM year will be required.
Yeah, you know, I think that the question of the CQM upgrade is fuzzy when it comes to using 2014 or a combination 2014 and 2015 in 2018 for the hospitals, because I do think CMS is trying to standardize the information, but exactly what that means as far as your CQM reporting is something that I'm hoping we're going to get better clarification on, because clearly if you have to report to the most recent set of CQM standards, then that's going to impact which quarter we end up reporting for the hospital.
Okay, next question. There is an exception on the request accept summary of care. If you meet the exception, are you required to take it, then meet the measure of the other two? You know, there's very few of the exceptions within meaningful use, or now on the EP side, it's called HCI, that you have to take. I always have seen the exceptions, like let's say if you don't pass 100 unique patients, we saw that with the ERX and the orders. But if you're meeting the measure, regardless of whether you're above or below the exception, report on it. I've always said.
Yeah, and the exception on, for example, the sending out electronic summary of care has to do with whether or not you're in an area that is identified as not having adequate coverage, and yet in Ohio that is only one county. So I'd say at this point that you would want to report on the other two. The exception, as is usually the case with CMS, is only if you cannot meet the other two. So if you would have an exception for 2 out of the 3 measures rather than 1 out of the 3, you'd still have to report on the other 2.
And again, the meaningful use requires that you meet 2 of the measures, but you report on all 3. You can meet all 3 as well. That's our last question there. Let me check the chat box real quick. Oh, another one just came in. The exception is the number of patients never before seen by the provider, EH. That's I think there was language for on the query and accept one where if you didn't have 100 patients referred to you within the reporting period. But I thought
that's only on the EP side. I'm not aware that the hospital has a similar.
Yeah, usually on the hospital side, they did not have that same exception language.
Yeah.
Another one came in. Under proposed 2018 QPP rule, can we exclude the facility-based providers from our MIPS group data, or will the group have to meet the facility-based criteria?
Yeah, tricky. What I would say is no, the group does not have to, because that is an election unless the group elects as a group. For example, if you have a group of ED physicians who are manning your emergency department and yet you're responsible for reporting for them under your TIN, that they could take that facility-based as a group and exempt out. I mean, they have definitely stated that that is available to the group. But if it's, and the question is then, if they are part of your broader TIN, are they covered? Well, like any group reporting for TIN, they would be covered by the group reporting if it's an APM, and if they are part of the core group of the APM. But if they are just a contracted part, then I would say that the exception for facility-based reporting would apply.
So then what happens when you have virtual groups?
Oh, don't even get there. We don't have virtual groups in Ohio, I'm sure.
We had another question along the same line, same person. For IQR, did CMS change the quarter definition to
fiscal fee? Yeah, Steve, it is. It's what they did is, so quarter for hospital IQR reporting is not fiscal quarter. So it doesn't run October 1st through September 30th. It is calendar year. Everything's calendar year for reporting purposes right now, including for the hospital.
Yep. That was the last question we had. Oh, almost. All right, for 2018, meaningful use on the hospital side. Does secure messaging still mandate a message be sent to the patient? That is what secure messaging is. Secure messaging is between the provider and the patient.
It can count what a patient sends to you, but only if you respond. So they've totally, in 2015, they flipped the way the measure is captured, and it is captured when you send out an email, whether it's in response to another email or whether it's your own self-initiated one.
When we say email, it functions like email, but actually goes to your portal, or now that they're adding API functionality, it could go to some application as well. And a lot of folks do confuse that with the direct functionality, with the sending of the electronic referrals, because that's essentially email as well, though it's handled a little differently, and it can get confusing. But secure messaging is between provider and patient. Direct or referrals are provider to provider. There is a little bit of funkiness where if you go provider to provider and your EHR provides you a means of copying the patient, that can be counted towards a secure messaging as well.
Correct, but that's the only time where a provider to provider is counted in secure messaging is if the patient is copied on there.
And Stephen, you are making us work for this. That's hilarious. Again, guys, thank you so much.
It's so good to hear from all of you, and we'll plan on having you in September when we get ODH on, and I think we're also working on getting Medicaid, and then in October when we see the final rules.
Go to clinisync.org right now, sign up for our newsletter. All of our future webinars will go out in Dottie's newsletter that she sends out every month. So get signed up and you won't miss a webinar. Thank you for attending, and we'll get the recording of this webinar uploaded very soon.
Thanks a lot.